We're here to honor the Chauncey Leake Distinguished Lecture. That's a lectureship that's hosted by the Department of Pharmacology and Toxicology. So today we get to honor two exceptional scientists, one, Dr. Chauncey Leake, and two, our special guest today, Dr. Herbert Meltzer. For those of you that don't know the history of Dr. Leake, he's considered one of the founders of modern pharmacology, if not the primary founder of modern pharmacology. He published over 25 books and 600 articles, but we hold a special place for him in our hearts because he served as UTMB's Vice President and Dean of the School of Medicine between the years of 1942 and 1955, and he's the only, in all the 150 years of UTMB's existence, the only PhD that's ever held this position. So it's still holding since 1955. Dr. Herbert Meltzer was selected competitively by the faculty in the department and chosen as the 2014 Leake Lecture because he embodies the scientific and clinical spirit of Dr. Leake. He's a graduate of Cornell, Harvard, and Yale. Yale is where he received his MD, and he's arguably the most prolific and influential scientist in the field of neuropsychopharmacology. He conducts clinical research routinely, clinical trials on novel medications, and is invested in genetic biomarkers for cognitive disorders and developing novel therapies for schizophrenia, particularly treatment-resistant schizophrenia, which is a real problem in our area. But that's not enough. Dr. Meltzer also runs an incredibly productive preclinical laboratory in which he studies animal behavior in various models and microdialysis of neurochemical markers. And that's still not enough. He's also a practicing clinician and sees patients and treats patients with evidence-based psychiatric methodology. To date, his efforts, and I have a CV from, I think, a couple of months ago, his efforts have resulted in 936 peer-reviewed primary research publications. That doesn't include 122 book reviews and special articles and 151 book chapters. I don't know where he finds time to be what I consider the quintessential translational investigator in neuropsychopharmacology. On a final note, Dr. Meltzer is a fascinating person, and we will have immediately after this, we'll have a reception on the third floor of BSB, and I welcome you to come meet him. He's a world traveler, very interesting conversationalist, and been a mentor to me for years, and I'm really happy to see him here today. So please join me in welcoming Dr. Herbert Meltzer, the 2014 Chauncey Leake Distinguished Lecturer.
Thank you for that overly generous and wonderful. I wish I could live up to it, but time will tell. This lecture is in part really a homage to Catherine. I gave a version of this, which she missed, traveling to South Africa to the Serotonin Society. And it was very appropriate to give an all in the serotonin receptor family there. The story, as you'll see, that I'm going to tell you today is not all serotonin. That was my charge there. But it certainly plays a absolutely central role. And I've had the wonderful morning talking to people in the Department of Pharmacology, which I want to express my gratitude for choosing me to give this great honor. And there's a lot of overlap between the work that I'm doing that relates more to the cognition in serious mental illness and the addiction, impulsiveness that this is the world center for. The laboratory that Catherine has just can't be duplicated, isn't duplicated anywhere else. So I'm going to discuss some key concepts guiding psychotropic drug discovery for schizophrenia and related illnesses and neuropsychopharmacology. During this visit, I learned how the absence of knowledge about some of these concepts really hurts eminent scientists getting grants funded because of misinformation that's out there. And so you'll have to endure as I go through what the misinformation is and my efforts to try to get the story straight. We'll see who's correct about them. I'm going to talk about a novel antipsychotic, not directly involving dopamine. This is really a game changer that came out of our efforts to understand clozapine. It's called pimavanserin or Nuplazid. It's fast tracked by the FDA for treating L-dopa psychosis, and it's going to, I think, have a huge impact on treating a number of other neuropsychiatric disorders. This issue that I related to that the field has largely gotten wrong recently is related to the cognitive impairment in schizophrenia. And I need this to set up the basic research that I'm going to talk to, an approach to developing novel drugs for cognitive impairment based on the NMDA Glutamate receptor antagonist, PCP, ketamine, MK1 model in rodents, and trying to show that this really does or does not translate into treatments for schizophrenia and helping us understand the role of glutamate in schizophrenia. I asked for, and Barbara kindly sent me information about Chauncey Leake. It is a great honor to hold this lectureship this year. He was a pharmacologist, toxicologist, teacher, administrator, educator, historian, and I have a great deal of interest in the history of psychopharmacology, and an academic adventurer. Like me, he moved everywhere, always in search of a better place. And believe me, moving has its advantages, as staying put does also. He had special interests in public policy, arts, humanities, and philosophy. I started out in college as a philosophy major and then discovered chemistry. He, like I, have done research in anesthetics, amphetamine, and hallucinogens. Wrote a nice review on hallucinogens. And this is a quote from there. He was sympathetic to the tough problems continually faced by drug companies in trying to develop new drugs. I will echo that sentiment. And then at the end of this review of his life's work, he had just retired. He wrote, I'm still in it for the excitement, the knowledge, and the fun of pharmacology and related matters, and I couldn't agree more. Okay, so there are 14 serotonin receptors. Every single one of them is important, and even for things like cognition. And I wish I had time to go into all of them. These are my 5 most favorite ones. The ones that I'm going to focus on today are the 5-HT1A, 7, and 2A. I think we're going to develop some nice collaborations with Catherine and many people in the department, and the 5-HT2C is going to come up at that point. So what are these invalid? I was going to first show this slide and not tell you that they were invalid, but they really are invalid, but they're deeply held beliefs by many people in the field, that psychosis is the core clinical feature of schizophrenia. There have been no novel drugs for the treatment of schizophrenia since chlorpromazine. This was Eric Kandel saying this on Charlie Rose a few years back and reiterating it many times since. Atypical antipsychotic drugs are not superior in overall efficacy or safety to typical. Remember, this is invalid, as I will try to show you. The atypicals are not superior for cognitive impairment in schizophrenia. And that neither drug can help anybody in cognition, so this is a completely unmet need. The root of some of this misinformation is not understanding the role of tardive dyskinesia in how problematic it is in cognition in particular. On the basic pharmacology is you cannot pick up a serious review article in this field that won't begin with saying that only dopamine-acting drugs are antipsychotic. That the animal models of cognitive impairment for schizophrenia are invalid and don't translate, and that glutamate and GABA are not viable targets for developing drugs for schizophrenia. There were a couple of failed efforts recently more than a couple, and so that has been abandoned for the time being. And then there has been, up till now, very, very little emphasis to developing new drugs based on serotonin pharmacology. And I'm going to try to show you that these ideas are not correct. And I added this slide last night thinking of some of the things I heard talking to the faculty here, that basic science, which clearly doesn't depend on clinical science for it to do knowledge, and someday the really good basic science will drive clinically relevant material. On the other hand, the lack of understanding or misunderstanding of clinical issues is going to impair the allocation of resources for basic research, as is the case now with the effect of atypical antipsychotic drugs and their application for treating cognitive impairment. So if you start with the premise that you're going to study atypical antipsychotic drugs in an animal model, you're not going to get your grant seriously considered. Well, this is years ago, before there was something called RDocs, I wrote about the need to get rid of the concept of diagnosis, or not to get rid of it entirely, but to work in this multidimensional concept. I wrote a paper outlining that idea in 1975 and repeated it in 91 with a more exhaustive data. And the basic story is these are 4 independent dimensions in schizophrenia and bipolar disorder, and once you study cognition in one of them, you're bound to come up with information that's relevant across the whole spectrum of serious mental illnesses. This is not to say it's irrelevant to study from a diagnostic capacity, but it's caused more problems than it's solved, and I think it's a very good move to limit its sway in research design. Well, as Catherine mentioned, I've been extremely interested in treatment-resistant schizophrenia. These are the 30% of patients who failed to respond to any typical or even standard doses now of atypical drugs. And about 20 years ago, I showed with John Kane in this study that's been cited about 3,000 times now that the Clozapine is more effective. Oops, I know I'm going to do that. Is this the laser? Let me use the pointer down here. Clozapine, compared to chlorpromazine, is more effective in improving global psychopathology in these 30% of treatment-resistant patients, in treating the delusions and hallucinations that define the syndrome, in improving negative symptoms in those groups. And after that study was finished, a randomized clinical trial, I went on to show that another 30% of patients treated with clozapine responded late. These late responders, and that, as you'll see, turns out to be a crucial finding in some of where I'm going. I've actually now replicated that this is not unique to clozapine, but others of the atypicals, that melphalan, olanzapine, and depot-risperidone can also produce data like this if you use the right doses and particularly the right duration of treatment, namely prolonged treatment. In the middle of that study, I tried to find out what the pharmacology that distinguished clozapine from chlorpromazine. And to make a long story short, we found using drugs that I knew about from the preclinical and clinical literature of the late 80s, that what distinguished them was strong serotonin 2A receptor blockade. This is the serotonin receptor that is key to the action of mescaline, LSD, cortical, striatal, cortical descending pathways. What you needed to get an atypical response out of a drug was strong 2A antagonism and weak D2 receptor. You needed some receptor, D2 blockade, but if it could be overwhelmed, the beneficial effects of 2A receptor blockade could be replicated and could be obscured. And I wish I had patented that idea, which I didn't, but it went on to develop a whole class of drugs that are now the standard for treating psychosis. But what I found at the time was that these drugs were not strictly 5-HT2A/D2 antagonists. They had a number of properties, all of which mostly were pointing toward serotonin, particularly 5-HT1A partial agonism, a very much neglected and misunderstood target because we've had 1A partial agonists with weak intrinsic activity like buspirone. But then we also found important contributions, and I'll go into the 5-HT7 today in particular, effects of the atypicals that modify the core 5-HT2A/D2 picture. Partial dopamine agonism replaced direct D2 receptor blockade in drugs like aripiprazole, and alpha-2 adrenergic antagonism has also been shown to contribute to some of the beneficial effects of these drugs. These are some of the drugs, not sure why some of them are bolded, of the atypicals that have now really come to dominate the market. Not all of them are available in the United States. I would say roughly around the world now, 90% of people with schizophrenia, when they get an antipsychotic, receive one of these drugs. And this is, okay. An interesting finding that I helped Ryan and Roth and myself figured this out, that amisulpride, a supposedly selective D2, D3 drug without any serotonin activity, Brian screened it at my suggestion, and we found very potent 5-HT7 antagonism, which turns out to be crucial for its antidepressant and cognitive enhancing properties. And this is just a little bit of the data that shows about the etiology of schizophrenia or psychosis in relationship to 2A. So there is an upregulation, a downregulation of 5-HT2A receptors due to too much 2A receptor stimulation. In first episode, never medicated schizophrenic patients has been replicated by 2 groups. And also it could be potentially used as a biomarker for at-risk individuals in the prodrome. So there's elevated 2A activity, which helps you understand why a 2A antagonist might be useful. Okay, and on the basis of that, I won't go into the details. I work with Acadia to, and I should tell you I'm fortunately a small stockholder of this, to develop a selective 5-HT2A inverse agonist, help them get funding from the Stanley Foundation to do this, what we thought would be a proof of concept study in people with a pure dopamine psychosis, an L-dopa psychosis. And these were the data we published, pimavanserin versus placebo. And these are very difficult studies to do. They've been, I won't go into that to talk in the discussion, but we got the right answer, I believe, with this. Clozapine at very low dose, Seroquel works the same thing without causing motor side effects. But this is really this study was then replicated in a big phase 3 study, and the FDA decided to accept this study as a phase 3 study, and the drug should be available in the next 6 months, or maybe a little longer. And will be used very broadly to treat psychosis. I also was able to get some funding to do another pilot study. For my original intention was to show that we really didn't need high doses of D2 receptor blockade to treat psychosis. And what we did was augment 2 milligrams, a sub-effective dose of risperidone, or haloperidol, 2 milligrams, which turned out to be not sub-effective, with the 5-HT2A inverse agonist. And these were the results. This is published in Schizophrenia Research. This is the placebo. This is now the improvement in the total psychopathology. And you can see it doesn't really show up in terms of mean scores, but all the other groups did very well, including this is 2 milligrams of risperidone placebo. When we look here at responders, classical definition, 20% improvement in positive symptoms, or in total PANS rather. There you see the best therapy was the 2 milligrams of risperidone plus pimavanserin. And eventually the Haldol and the high-dose risperidone picked up, but this is still needs to be replicated. It will in the next year or two. They're going to go back to try and improve this and get an indication. But we saw markedly less side effects all across the board in this group. So more rapid onset of action, fewer side effects, and it should work with all atypical antipsychotic drugs. And so things like the weight gain with antipsychotics will be diminished. The most interesting finding I think I made in these early years with clozapine was this finding, and it's proved to be the most controversial. And that is that over a 6-month period of time, in these treatment-resistant patients who are, like all schizophrenics, 1.5 to 2.5 standard deviations below normal on a variety of cognitive functioning. And this is true from even before the psychosis emerges in the prodrome period. Nevertheless, we got a 0.5 to 1 standard deviation improvement with clozapine in semantic memory, speed of processing, long-term verbal memory, nothing in working memory here, and nothing much in executive functioning. This was greeted with great derision when I first published it, but over the next 5 years, 20 studies were done with a variety of atypicals showing exactly the same rank order that I've just described in that original study. And then a few years after that, I, with a graduate student, meta-analyzed another 20 studies, and again, we basically replicated the semantic memory, long-term memory, etc., profile of atypical antipsychotics. So things seemed to be going well. And then what happened, there was something called the CATIE study that couldn't replicate these results, that found no difference between typicals and atypicals in improving cognition, and attributed whatever benefit there was to a practice effect. And this, if you again pick up the review articles, is what you see in the literature and what's bedeviling preclinical scientists who write grants to study this. Well, it turned out in 2011, the data in that paper were reanalyzed, taking into account tardive dyskinesia, abnormal involuntary movements. And once you took that into account, what did they find? They found the same thing that I reported here. This was an artifact, this lack of difference, due to the failure to have a truly randomized study and to take into account this key variable. There's now been another meta-analysis. These are mostly 6-week studies using long-term studies like 6 months and beyond. It's again a replication of the advantages of the atypicals over that. But by no means is this the accepted field. Now, what's the problem here? The problem is that the heterogeneity of what we call schizophrenia or bipolar disorder is so great, particularly when it comes to cognition, that it's really only some people that these drugs are helping. And even D2 receptor blockade only helps 70% of people. Clozapine only helps a subgroup of the treatment resistant. Well, what this slide shows in verbal fluency and in speed of pursuit, up to 50, 60% over time will respond. And yes, there are some people that respond to D2 receptor blockades, but there's a clear advantage. And as I see it, the task is personalized medicine to find the genetic and the biological basis for why some people respond and others don't. So the New York Times, as usual, came to my rescue yesterday morning with this article. Not that I needed them, but I thought it would be a great way to introduce this idea of exceptional responders. And what they're talking about in this article is In a cancer study, 2 out of 50 or so people had exceptional improvement, and they found the genetic basis using whole genome analysis and mTOR, one of the signaling molecules. It's also, by the way, very relevant to schizophrenia. So this rung a bell, as you see, for the following reason. Now, this just shows you one of many studies how gray matter is decreased in schizophrenia and is associated with more severe cognitive impairment. Great. This is the loss of neurons, which, by the way, again, is something that people on study sections don't appreciate and reject grants that talk about the loss of neurons in the schizophrenic brain. So let me tell you about this exceptional patient. This happens twice in my lifetime. Should have picked it up on the first time, but this is the most recent and most striking. This is a 47-year-old woman who from age 14 to 18 presented as what Bob Hirschfeld would agree is a bipolar history, typical manic, suicidal, impulsive, agitated, etc. She never had another manic episode in her life that I could determine. And then for the next 20 years, she presented as a repeated major depression, sometimes with psychotic features, treated mostly with antidepressants, never diagnosed as schizoaffective. The psychosis was all related to the mood disorder. But in her late 30s until when we saw her at age 47, she had an absolutely horrific schizophrenia course with severe persistent auditory hallucinations, a marked decline in her function. She had been a school teacher, a mother, wife, all of that fell apart. She was very close to chronic institutionalization when, out of desperation, she got referred to one of our trials for treatment-resistant schizophrenia. She'd even had a trial of Clozapine for a few months, but the dose was too low and she probably had polypharmacy. She came in, she was on mega doses of 2 antipsychotics. And she got randomized to a long-acting injectable risperidone, and she'd always been very compliant. She got 100 milligrams a day for 6 months. And this is what happened. Of the 160 patients in the study, she was the most severely ill. She had a PANSS score of 110. This is the ratings of her hallucinations and delusions. These are the maximum possible ratings over the course of the 6 months of the study. Our very astute rater picked up a mild improvement at week 12 here, but then she goes to sleep one night and she wakes up and all the delusions and hallucinations were completely gone. She was baffled. She reported it to her common law husband, and then we began to intensively work this up. What we didn't know, because the study was blinded and someone else was doing the ratings on our team of cognition, this lady who had the worst cognition of anybody in the study was showing some dramatic, even this is really unprecedented in this test. Remember, executive functioning is something these drugs don't usually work. And then she had half the way to normal and then basically was normal from week 12. Meanwhile, she's grossly psychotic at that point. She's still grossly psychotic at 6 weeks and 12 weeks, but nevertheless the cognition. So this is another shibboleth about the field that's totally, this woman violates that principle. Now this was all 4 years ago. She's remained in complete remission since then. Now fortunately we had scans on 30 people pre and post, and after all was said and done about the scans that were usable. Now we've had 2 world-class brain imaging teams separately, blindly analyze these images, and this woman, this is a summary from the Harvard-trained team that is now at Northwestern. She had changes in gray matter between pre and post time points compared to the rest. This is just the methods. Both of them basically did the same. And what am I doing here? Well, Okay, yeah, here's what I want to show you. So overall, there was a decrease in gray matter in the rest of the people in the field, but this is her. She had about a 15% increase in gray matter throughout her brain. But particular areas, both teams found the same thing, increased gray matter density in large areas of the posterior cingulate cortex, motor area, superior and inferior colliculus, subthalamic nucleus, and the left parahippocampal gyrus. And we have fMRI data that goes along with this kind of improvement. This is the cingulate cortex, subthalamic nucleus is a circuit that's been well described by neurologists in the syndrome of akinetic mutism, and there's some things about it, but the real point is she has a reversible disorder, and we can discuss what that disorder was. She's remained in remission for 4 years. We're going to be following this up with a whole variety of ways to try to get at the genetics of this. But the point is it's treatable. Cognition can be improved. If you don't believe what I showed you about the meta-analyses, this is unmistakable. This is truly unmistakable. I have another case just like that I could tell you about. So then the question shifts to why is this happening? So when I first saw the cognitive impairment in schizophrenia with clozapine, we looked to the usual suspects. It's well known that dopamine and acetylcholine in the cortex, were, I guess it's, something should come up here that's not. Clozapine, risperidone, all the atypicals enhance cortical dopamine, basically sparing the nucleus accumbens with the exception of risperidone that has a good effect there. Haloperidol, the picture is just the opposite. All the typicals enhance limbic dopamine with very minimal effect in the cortex. Is this? Okay. We've done many studies on that. I'm not going to dwell on them, but 5-HT1A partial agonism, along with the D2 antagonism, is a key part of the difference. This shows that the 1A antagonist blocks that increase in dopamine, even in the atypicals that are not 1A partial agonists themselves, like risperidone and olanzapine. Clozapine is a 1A partial agonist, so it made some sense that whey would block that. The same kind of differential by and large, but again, clozapine stands out, olanzapine, acetylcholine. So cholinergic mechanisms are a critical part of these drugs, and this is very important. We're going to have probably the first approved drug for cognition in schizophrenia is going to be an alpha-7 nicotinic receptor agonist. How does it work? By stimulating the release of dopamine and acetylcholine, just what I just showed you. And they're going to be used to augment these responses. Well, this is a way of segueing into the whole idea of the complexity of the brain and the signaling, the G protein coupled receptors and growth factors that signal together to eventually turn on protein synthesis, turn on the gray matter recovery in some fortunate individuals. Why don't the drugs work at all? Because of the complexity of these pathways, as that's my belief, and we're going to eventually have to get down into the SNPs and so on that affect these things. But it's the coupling of the excitatory and inhibitory coupled, G-coupled receptors and growth factors like BDNF that are involved in this. So it's been known for a long time now that there's a glutamate problem in schizophrenia, which is why people like Ken Johnson here and myself spend a lot of time working on the animal models that involve glutamate antagonists like PCP and ketamine and MK801. They exacerbate cognitive impairment and controls in schizophrenia. They induce psychotic symptoms. There has been a well-documented loss of GABA into neurons in the hippocampus and prefrontal cortex. in patients with schizophrenia, leading to an overactivation of the excitatory glutamate neurons. There have been many, why do you have decreased gray matter? It's made of not only of neurons, but of the dendrite spines, glutamate receptors located on them. And again, the PCP glutamate model is intended to mimic these kinds of deficits that have been shown in schizophrenia. There have been some positive trials with drugs that enhance NMDA receptor functioning, namely glycine agonists, but a recent flameout of a glycine transport inhibitor to test for negative symptoms in cognition really devastated people. MK07, this is a little later, is a drug that I'll show you about, also called TPA-023, which stimulates GABA A receptors and was originally reported to improve cognition, and then an attempt to replicate those work failed, leaving people befuddled about this whole story. David Lewis has really been the pioneer, I'd say, in this. And the basic idea is that when you block NMDA receptors, as you see here and here, you on the inhibitory neurons, you get an overexcitation of these pyramidal neurons, or principal cells, as they're called sometimes. The AMPAR receptors are normal. They can, and as glutamate pours out, you get these neurons dysfunctional. And I will show you that in our animal model. So the output of these neurons are hyperexcited. Why would a 5-HT2A agonist be problematic? Because it further stimulates these neurons. Why would a 1A partial agonist be therapeutic? Because it hyperpolarizes and slows down these neurons. So we have all these clear-cut pharmacological translations of the NMD hypothesis. The 5-HT2A receptors, as I mentioned, Brian Roth and others have shown that they're a key part of the PSD protein. It starts off a lot of the signaling on these spines, and 5-HT2A antagonism, inverse agonism, is a key role in restoring and the surviving of spines during challenging situations. And you'll see what I mean in a moment. So as a way of studying this, we have adopted a different model than Ken Johnson uses here, but we certainly were not the pioneers. Basically, we study adult mice or rats. This is our mice protocol, in which I should say a word about novel object recognition. A rat can remember for the mouse for up to 24 hours if it's seen an object, and when it sees a novel one, 24 hours later, it'll spend a lot more time looking at the novel object. So here's the acquisition phase. 24 hours later, we expose it to this, and a healthy animal is going to spend a lot more time looking at this. We call it the discrimination index. In the rat, the protocol is a little different. We use a 3-minute intertrial interval because after giving PCP to the rat can't remember even for 1 minute that it's just seeing these two objects. So this is what you see here. This is the rat kind of data we get. They're exploring well for the 3 minutes we give them to explore. They're habituated to the arena that we do this in. It's all videotaped and then rated blindly afterwards. Then after the intertrial interval, the vehicle animal will explore the novel one. The PCP animal can't remember and explores them equally, and we get the DI of, you can see, about 0.5 in the rat. It's usually 0.3 in the mouse. And the treatment that we use is when we give the PCP, is 10 milligrams per kilogram twice a day for 7 days. We could actually do this for 3 days. It does just as well. And in the mouse and the rat, it's much lower dose, 2.5 milligrams per kilogram for 7 days. And then, of course, what my interest was to see, do these atypical drugs make a difference? Well, they sure do. This is the normal rat. This is the effect of the PCP, which is given for a week. The animal is washed out. And then indefinitely, 3, 4, 5, 6 months later, the animal still can't figure this thing out. And if we take subtherapeutic doses, the atypical that we've used is this one from Dinapon Sumitomo, lorazepam. You can see at these very low doses, no effect, and then we get, we hit what we call the effective dose range, 1/10 of a milligram per kilogram, and the phenotype looks perfectly normal. We've restored, this would be the equivalent of the declarative memory test in our patient, verbal learning. This is the rat equivalent because it's parahippocampal to a large extent. Well, what do the typical drugs do? The typical drugs do nothing. We've studied haloperidol, profenazine, thioridazine, and they look like this. And in fact, if you give even a little bit of the haloperidol, increasing the D2 receptor blockade, you can wipe out the effect of the atypical drugs. It's very sensitive. Another strategy we've employed to get at this is to take a sub-effective dose of that lorazepam that I just talked to you here, 0.03. Remember, the effective dose was 0.1. And then when we add back the 5-HT2A antagonist, we restore the ability to remember this. And we've done that with a variety of 5-HT2A antagonists and a variety of atypicals. 5-HT2A D2 ratio being confirmed. Now, I had good fortune to collaborate with a superb electrophysiologist and Jan at the University of Buffalo with this model. And what she found was that in the slices from the prefrontal cortex of PCP treated mice, rats rather, excuse me, there was a decrease in the NMDA receptor current. However, if we pre-treated with lorazepam, we restored the current basically to normal levels. The same thing happened with clozapine. It did not happen with haloperidol. So we got in the cortex a restoration of glutamatergic function. This is some work from Bob Ross' group at Yale, in which they looked at synaptic numbers, excitatory NMDA receptors, in monkeys treated with PCP, and they found that there was a marked decrease in the number of receptors, synapses, excitatory synapses, and that was restored by olanzapine, and not by haloperidol. Said monkeys, I guess it was rats, I'm sorry. Okay, now going back to Zhen and her group with us guiding the studies in a sense, she was able to show that what had happened was a decrease in NR2B receptors in the PCP treated animals, and that with lorazepam we had a restoration of the NR2B receptor density. The NR2B is now the hot subcomponent of the NMDA receptor because it's apparently the target for ketamine in treating depression. I'm going to quickly go through some of the other mechanisms. This is studies showing the 5-HT1A partial agonist work. And by the way, this is the one mechanism we have translated in man. I've done a study in Japan with this drug, and it shows that tandosterone, where it's approved for anxiety and depression, is also able to enhance cognition in schizophrenia. So this is just a cartoon to look at the location of the 5-HT1A and 2A receptors on GABA neurons. 5-HT2C receptors are also a part here, but not particularly shown in this graph. And I mentioned the effect of the 5-HT1A and 2A receptors to either to change the excitability of the pyramidal neurons. So we did the logical experiment, and this has just been published in brain behavior research now. And what we did was try these various combinations and eventually put them all together to see with a 1A agonist, with a 2A antagonist, and a D2 antagonist, could we get some benefits? So here's the 2A antagonist, the D2 antagonist, we get no restoration. Here is 1A agonist, 2A antagonist, no restoration. These are giving these drugs 30 minutes before the time of testing for acquisition and so on. Now, what happens when we give the right doses of a 1A agonist, a 2A antagonist, and a D2 antagonist? We get basically the profile of an atypical antipsychotic drug. So for this particular cognition, and we have similar data for some executive functioning, which I won't go into, but you basically can recreate an atypical manipulating these two serotonin receptors. They're not the only ones as well. Does this translate into man? We don't know the answer to that yet. Hopefully will. The other way we work with this is to try to prevent the deficit in the first place, because what we want to do in schizophrenia and other psychiatric diseases is identify them early on and treat them with the atypicals or whatever else is going to work and prevent it, or to produce an enduring reversal. And this is an example of prevention with the 2 at a time strategy or the 3 at a time. And we were able to prevent the effects of PCP, to impair the novel object test with these doses of haloperidol, pimavanserin, and tandospirin. And this is the prevention experiment. We have something called the enduring reversal. Well, let me switch back, go into the 5-HT7 receptor, because we think this may be really an extraordinary target. And here, what Zen-Yan, after we had seen this 5-HT7 antagonist, SP26990, worked just like an atypical, all by itself. And you can see this enormous effect of the 5-HT7 antagonist to enhance lurasidone in the PCP treated animal. Whereas here now you can see the haloperidol, no effect. So 5-HT7 alone, or a sub-effective dose of it and lurasidone, and we can restore it. So I've been able to work with another electrophysiologist at Northwestern and this contractor. And the story in the hippocampus is quite different. We don't see any deficit. He doesn't see in slices, and he's like Zen-Yan in terms of this is his lifelong work. No effect on NMDA or AMPA or NMDA currents to induce long-term potentiation. Here it's excitatory potentials in hippocampal slices from our PCP treated mice. But in the hippocampus, we see the deficit in long-term potentiation. That's what you're looking at here, and a deficit now in the hippocampus in the excitatory potentials. And this is going to be submitted next week for publication. what he's found, and this is really crucial, and if this turns out to be correct, here's our interpretation. When he tries to induce LTP in the hippocampal slices, what he finds is there's been an upregulation of the GABA receptors, but it's it's a failed attempt to restore inhibition. So there's an overexcitation of these pyramidal neurons. There's inadequate inhibition coming from the GABA system. And the prediction is exactly what David Lewis had made from his work in the postmortem of schizophrenics. What Lewis found was an upregulation of the alpha-2 subunit of the GABA-A receptor on the axon initial segment of pyramidal neurons in the cortex. Not that he didn't look at the hippocampus. But he then predicted that what was needed was a GABA-A agonist, which led to that MK077 study, which he said worked. It was the NIH study that said it didn't work. But what Anis and I are working on is that what we have found in the PCP model is entirely consistent with this schizophrenia model, and that's what you see here. A deficit in these parvalbumin positive chandelier cells, and then a need for more GABA-A stimulation. Well, here's our NOR data with the GABA drug, the same one that was tried in schizophrenia, and it's working beautifully. Let me, I'm probably wanting a little weight as I knew. This is critical. The 5-HT7 antagonists that we've used can restore long-term potentiation there. We have been trying to look at what's going on in the chemistry of this NOR during the course of the different phases. And we do that with microdialysis probes in the cortex and the hippocampus while we can measure the NOR that you see here. The lorazepam is storing it. And I'll just show you this. So here is our ability using mass spectroscopy to measure multiple neurotransmitters over time. And you can see in the prefrontal cortex the importance of a glutamate response and an acetylcholine response only in the saline animals. These do not occur after subchronic PCP, but other things are taking place in the subchronic PCP that restore function, but not in the same way. One of the interesting findings here was a big decrease in GABA. Now in the hippocampus it looks entirely different. Again, I'll just show you frontal things happening in dopamine, acetylcholine, and glutamate. I've summarized this over here, and then I'll stop because it's running late. Acetylcholine, dopamine, glutamate in the normal animals, not happening with PCP. Glutamate and norepinephrine occurring in the lorazepam-treated animals. In the retrieval phase, you get this profile. You get something fairly similar with the lorazepam-treated animals, but you get something very different. And we hope to extend this to look at all the different mechanisms to see what's common. So let me just, where are we? Let me conclude here. I'm sorry, I didn't time this terribly well. Serotonin receptors have been underappreciated as targets for psychotropic drug development. I particularly think that 2A, 1A, and 7 are the best targets now for cognition. The heterogeneity that I showed you most strikingly with the woman who recovered so dramatically is just the most visible way to show you how variable this is between patients and the need to study people like that to understand the mechanisms. And I do believe these animal models do have some relevance. We've already seen some translation, and I look forward in the next few years to refine these models and be able to help develop some new drugs for this purpose. I want to stop there.
Questions for Dr. Malta?
Yeah.
Your patient had the dramatic increase in cognition. After a while, did she ever get off of the drugs? And if so, was this maintained, or is it only?
Yeah. No, we're fearful about taking her off the drug, and she wouldn't dream of coming off of it, so I can't call it a cure. My feeling is, as we've seen, I didn't show you the animal data, but we've seen all this go away after we stopped the treatments. So my prediction is she'd be right back to where she was. What we do think is going on is that circuit, this anterior cingulate subthalamic nucleus, was really restored. That's why it was like a light switch overnight. It happened during sleep. I don't know if that was not. But we hope to look at that circuit through EEG methods. Yeah.
There's sort of a big thing that's going on with psychological disorders such as schizophrenia might not just be one disease, but multiple diseases that present in similar ways.
Yeah.
I was just wondering what your opinion was on that, and if it might explain the few patients that respond.
Yeah. Well, I absolutely agree with that. That was the point of the 1975, 1991 papers, in essence, that there are multiple different ways to get this phenotype we call schizophrenia. And I think, I made the comment during briefly showing you the signaling slide to say the heterogeneity was going to be there, but it's also going to be up at the front of the cell surface, if you will, with the G protein coupled receptors and that. So you can get to this disordered phenotype in a whole variety of different ways. We have labeled it schizophrenia over the years, but it's not a single disease by any means whatsoever. And for those of you who are not clinicians, the fact that this woman could morph from a bipolar history to a schizophrenia at the end of it, that had been described in the literature a bit. Bob Hirschfeld, I don't know if Bob is still here, maybe not. We both had the same teacher, Jerry Claremon, who delighted in pointing out those kinds of cases that occur. So there's no way to rigidify those things. Multiple diseases, and that's why if any of you are writing an NIH grant, don't talk about diseases, just talk about dimensions. If you mention diseases, you get triaged out. So it's an extreme, but Tom Insel has the money, so he can spend it whatever he wants. Well, yes.
Would you be able to comment on the overlap in cognitive impairments with substance abuse and the mechanisms?
Overlap in cognitive with which?
Mechanisms underlying cognitive impairments, especially at the neurotransmitter level that you showed with schizophrenia model. Would there be an overlap that you think with cognitive impairments associated with substance abuse?
In substance abuse. For sure. Again, is substance abuse the single? I'll defer to the world's expert here. It's not a single entity, but actually one thing, I didn't talk about it today, sometime soon I'll tell Catherine what we know about the 5-HT2C receptor. We know, we have a paper actually, I didn't get a chance to, and I'll send it to you, just got accepted. One-third of this, one-half of male schizophrenic patients have a very blunted response to a 5-HT2C drug. We're looking at temperature response. Hormone responses are okay with that, but there's that kind of overlap. So you're going, I don't think the mechanisms will be unique, okay? That's my point. And actually, 5-HT2C agonism, which there's tremendous amount of work going on here, developing positive allosteric modulators and others, that's a very promising mechanism for cognitive impairment as well as for treating. There's already a study with a drug, vabicacerin, showing that it's effective to treat schizophrenia. Drug companies have shied away from it, but there's efforts going on in multiple laboratories to develop. Now, the thing about the 5-HT2C receptor, and I better be careful here, is because of functional selectivity, not all agonists are the same. And I don't expect all the 2C agonists that are being directed. Maybe the positive allosteric modulation strategy may be more useful. But I just came from a big conference on, well, here's another interesting thing, and it speaks to non-specificity. Magnesium ion is crucial to the NMDA receptor. It sits in the channel and there's a magnesium block, which apparently is inadequate in a variety of diseases. I say apparently. Why? Because there's a Chinese scientist, investor, who's really pushing a preparation of magnesium for treating cognitive impairment in ADHD, Alzheimer's disease, schizophrenia, and anxiety disorders. We're going to do the schizophrenia study. The anxiety disorder study is completed, and I've been told the results are very positive in a placebo-controlled study. And I don't know about but if you look, so why did we do this in schizophrenia? This same magnesium preparation works like tandosterone or some of these others to augment atypical antipsychotic drugs in various animal models of cognition. That comes from a very good group in China, and I'll be publishing it shortly. So the cognitive impairment does not map to anything that looks like DSM-4 or 5. And therefore, the opportunities from drug development are just enormous. The problem is the FDA, and the companies have to follow the FDA. The FDA is still locked into the disease model. And so what I didn't go into today was this work we did with clozapine and suicide, which everybody in the world has now replicated. That's one thing that's totally uncontroversial. Clozapine reduces the suicide rate 85% in schizophrenic attempts and completions. And yet it's approved. The FDA approved it when we did it in a randomized control style. And it's never translated into studies in bipolar disorder, where suicide rate is even 3 times what it is in schizophrenia. Why? It cost $60 million for Novartis to do the study in schizophrenia, to replicate our original finding. $60 million. Nobody's going to put $60 million into the suicide study in bipolar disorder. Whereas if the idea had been from the start, you could study anybody who's intensely suicidal. I think the clozapine suicide story would translate into PTSD and be extremely useful for the veterans that we are so concerned about right now. And yet, because of being locked into the disease model, the science is one thing, the reality is another thing, and the study sections and the regulatory is another world. And if you're going to be successful like this lady, you have to be able to work in all those different frameworks. But the science is what's important. I'll leave you with that thought, that, and try to get the opportunity, as I have been fortunate to be able to follow the scientific leads. And sometimes they pay off. So the happy story about pimavanserin is the projections are it's going to be the biggest drug in the field of psychiatry. And they expect it to be, once it gets several more indications, it'll probably be selling in the range of $3 to $5 billion a year. So simple 5-HT2A inverse agonist. And there are a lot more opportunities there in the serotonin field. That's okay?
Thank you so much. We have one more thing. Don't clap yet. We have a commemorative medallion for you that's engraved, and I'll have it to put on your desk.
Thank you.
We also have a reception next. Oh, I forgot, your check's in the mail. You have an honorarium in the mail. That's
I'm
not
sure it'll be
available
there.
today.